Hello, you're very welcome to Transform, the digital government podcast presented by me, Maeve Neefsey. On every episode of Transform, we bring you top names behind some of the most exciting and transformative digital projects globally. On this episode, we meet the one-woman powerhouse that is Maria McCann, former Director of Identity Management with the HSE. So some of us have experienced that fear that we're having a procedure, the wrong medical records will get into the doctor's hands, and that'll result in our left leg being cut off instead of a mole removed. But she's part of the team to make sure that doesn't happen, or never happens, we hope. She's also part of the team that fought the war against COVID. She was responsible for making sure you knew when and where to get your vaccine, and also making sure that 4 million people went to the right vaccinations facility at the right time. And post the invasion of Ukraine by Putin, she made sure our war refugees in Ireland were properly taken care of. So Maria McCann, welcome to the podcast.
Thank you so much. I'm so happy to be here. An amazing podcast.
We're delighted to have you. Delighted to have you. I am genuinely excited because the more I talk to you, the more things I learned that you were involved in. The things that have changed our lives around us, particularly within digital government transformation.
Yeah.
So you're an organisational psychologist.
I am.
So how did you end up working with the HSE?
Yeah, it's so organisational psychology is my passion. I'm really passionate about how people are enabled and happy in their work in order to deliver really strongly in their projects. And my background is in IT, so it's sort of like this marriage made in heaven, maybe, that we've got IT, and then how do we get the people behind the IT that are actually delivering it to be really confident and able to deliver their projects. So I went into the HSE just when I was going back to finish my master's in organisational psychology, and had the blessing of being able to do my course at the same time. All of my coursework was all based on live projects within the HSE. So it was all really, really real and making that impact with the staff within the Office of the Chief Information Officer at the time.
Okay, so who was that at that time?
So I went in and worked for Richard Corbridge. So he was the CIO. He hadn't been in that long, and I went in to support around innovation and communication to begin with. And I was there for that particular aspect of supporting him around engagement, what that looked like for people, for the clinicians, for the staff, how do we do things better, and really trying to brainstorm and all that blue sky thinking about changing how we delivered IT within eHealth. It was a very exciting time.
And when was that?
That was back in 2016.
2016. So was this very novel, bringing in an organisational psychologist to work? Or is it a new role, or are they always considered it important?
Yeah, it was literally because I'd worked in IT and engagement and innovation. So I went in at the start for that sort of end of it and trying to look at how we basically brought people together to understand where they were at in their journeys, to understand the wider picture of communicating what eHealth was trying to do for the country, and trying to marry that all up, but really using user-centred design from a clinical perspective, from a patient perspective, and trying to bring everyone onto that same page from a communication point of view.
Okay, so just for all of us, tell us about what you mean by user-centred design.
So really, I love user-centred design. I work with some really incredible people in that space now as well as then, and it's very much about putting the patient at the centre of what we were delivering. So what is their patient journey? What does that look like? And how do we enable through IT to support them through that journey? And for clinicians. So within IT and the HSE, you had two stakeholders, your clinical teams who were using the technology. So how did you build the technology actually around what they needed it for, not just what the IT could do? So It really needs to be driven by the clinical business team to say what it looks like, and the patients to say, well, this actually will work for me and this makes my life better.
So as an outcome, what you don't want to happen is people having to give the same information over and over again as on the patient side.
Yeah.
And the security that you've got all the information about them in terms of their records. And on the doctor side, how can you enable them to do things better? Or what are you trying to achieve? Or just listen to what they know in order for providing them with what is actually doable and usable for them. Is that what you mean?
That's it. And it's so basically with any IT projects worldwide, about 75% of them fail. So that's quite scary. 75% of digital transformation projects failing. And a lot of the time that's because of user adoption. So whoever you're building it for, whether it's a clinician or somebody that works in finance, isn't actually going to use the transformation project because it's not sustainably built for them as a person, not sustainably built around their journey. So quite a lot of the time what happens is IT builds stuff with requirements and then it's not actually designed around the user. So user-centered design for patients and clinicians in the aspect of the HSE was really, really important to increase adoption. And that the patients would look at whatever you're creating and go, yeah, this is brilliant for me. And the clinical people are like, this makes my life easier so that I can actually look after patients. Because the whole point of the clinical, they want to be able to be in front of patients. So how do we build an enabling technology that supports them as a tool, as opposed to something that they feel that they have to fill out and it's an extra chore for them as well? And that can only be done if we understand how they do their jobs, how they do their work. And a lot of the time in different parts of Ireland and across the world, everyone does things slightly differently. So when you're trying to build standards or doing requirements, it's quite difficult to do because Maeve, you might do something different in Sligo than what I do in Cork. So how do you look at that from a standardisation point of view, even though we're both the same type of clinician? So it's intense, but when we have incredible clinical people within the HSE, which we do, that we're really involved in actually looking at how do you create that the right way, and how do we know that Maeve does it this way and Maria does it that way, but we have to find a meet in the middle that everyone can use this technology and make it better for patients. So great clinicians helping us with that.
I presume there's times when people don't agree or they have to say difficult things. I know that you told me something interesting about your first week where you had to maybe tell Richard, your boss, something he didn't necessarily want to hear. So tell us about that.
And do you know what? It wasn't even that he didn't want to hear it. It was like, he was like, oh, interesting. I was only there about a week and you're always very nervous starting your new job and all that kind of thing. And I was sitting in a room in Richard's office and there must be about 10 people there. And we were talking about an animation that we created to look at communicating what electronic health records were. So that patients and clinical staff would be able to go, okay, that makes sense to me. Here's the benefits.
Just remind us what that is.
An electronic health record is when all your medical records are in one place. So patients can access them and clinicians can access them. So if you've got records in Cork and you've got records in Sligo and records in Kilkenny, that there's a way of bringing them all together. And the electronic health record is that view for you technically to be able to look at them all together. So trying to explain what that looked like and the difference between that and the Individual Health Identifier.
So you were doing a video, were you? An animated video to explain that?
Okay. Yeah, we had.
Or the benefits of it.
The benefits of it, what it was and the benefits of it. An amazing organisation called Think Visual were in creating it with us, and we were all having this conversation. I was only there about a week and we're having a conversation about building the animation and who we were going to get involved in building it and how we were going to create the storyboard. And somebody said, Richard, I think it would be great if you actually done the voiceover for the animation, explaining what it is. And for those of you that don't know, Richard is English. So I remember sitting going, I don't think this is going to land. An Englishman telling the Irish country about how their records are going to be brought together. And I'm from the north, as you can hear with my accent as well. I just was like, I just don't know. And I remember going, that little voice inside your head where it's like, just say something, just say something. And I remember going, can I say something? Putting my hand up. And look, they were a brilliant team. I was like, okay, have you tested? Have you spoken to the public? Have we showed the animation in raw format? Have we shown it to clinicians? Do we know if it's landing with the right message? And they were like, no, that's a brilliant idea. Let's do that. So I ran focus groups then for the public and for clinicians to say, what do you think? Does this make sense? Is this what you think an electronic health record is from a clinical perspective? And public, does this make sense to you? Do you understand the benefits of why we're doing this, why the investment is needed, etc. as well? And I suppose we changed a lot. Richard did not do the voiceover.
Funny that.
Yeah.
But you don't believe this kind of, I suppose, this kind of general belief that clinicians and healthcare workers don't want to see change, that they resist change, that they don't like technology. You don't think that's not your experience?
1,000,000% not. And in those early days as well, we set up a Chief Clinical Information Officers group. So it was clinical people who either had experience in informatics, had a massive interest in informatics, or had done health informatics in academic ways.
And informatics being?
IT. Informatics being IT. And that group swelled to over 200 incredible clinical staff across the HSE saying, we want to do things better and differently, but you need to let us drive it because we are the ones that know what the journeys are. We are the ones that work with the patients. And that was an incredible, incredible group driving innovation and change. And that group's still there. And in fact, My friend Michelle Kearns was one of the original people in it. She was the CIO for Boots. Oh, she is the CIO for Boots now. And she worked in eHealth for a long time, was the CIO
so
for CareDoc.
she came in from Boots into the HSE back out again?
No, she came from CareDoc. She was the CIO for CareDoc. And then she came in and done a secondment with us in eHealth. And she's one of my besties now. and then she left, actually, and went back to CareDoc after her secondment and then went into Boots. She's now the CIO for Boots. She was one of the original members, as well as Mary Swords. Mary was incredible. And a gentleman now, Professor Richard Green, who was the clinical lead for the maternity, newborn and clinical management system down in Cork.
Which won an eGovernment award, Ireland eGovernment award. It did indeed win an award.
It did. I remember it was brilliant. And at the time I was saying to you, Simon Harris was the one that actually presented us with that award as well.
That's
right. But Richard, for example, he is now the Chief Clinical Information Officer for the HSE. He works under Colm Henry, the Chief Clinical Officer within the HSE. And he is driving incredible change with that clinical hat on as to how we do IT better for clinicians and for patients. Another amazing woman is Loretta Grogan. She's the Chief Clinical Nurse and Midwifery Officer. And again, Loretta is a powerhouse. She is a true powerhouse. She's amazing. And she's driving that change, going, this is what it looks like as a clinician on the front line, how we deliver what we do. And you can't just do IT to us. They need to be the ones actually driving the IT.
So you don't really believe, or do you believe, that IT should be driving digital transformation projects?
No.
Who do you think should drive it?
So in the HSE side of things, it should be the clinicians and engagement with patients. And the HSE have come so long away as well. They're doing so much engagement. There's patient reps across multiple projects within the HSE now. So we have the clinical people driving the actual projects and the patients then also sitting on boards to talk about what that means to them and how it impacts them as well.
Very good. When you say reps, do you mean that they're like a champion for patients? And
they
saying,
are.
Look, this is what would work for us, that wouldn't work for us.
Yeah, there is a group within the HSE that actually do patient engagement, and they have like a lot of people that work with them to do patient engagement. And then there also is different like charity groups that we work with. So Derek Mitchell is the CEO for IPOSI, the patient... I actually don't know. I can't remember. Irish Patient something forum. But IPOSI, they're incredible.
We'll find it out. We'll put it up on the podcast notes. Yeah.
And they actually get involved in a lot of our projects. They work with us. And way back when Richard had just come in as well, and Fran Thompson, he is our CIO now at the moment, we ran groups with patients, focus groups of patients to talk about their journeys. And out of that, there were about 140 patient journeys created.
Oh my God.
Yeah.
So you mapped out exactly how the patient would move through to the HSE.
Exactly. People that had different conditions were all mapped out and they were all made available. So it was very much around open transparency and trying to support different organisations learning how to make their business better in order to create technologies for patients.
So you, for example, could you release those to the public so that somebody external could say, okay, I'm going to create a new technology that is relevant to the HSE, and they'd see all the customer or the client journey or the patient journeys and then be able to design something around them.
Yeah, all those personas were released. Yeah.
Okay, that's amazing. I mean, that does lead very much into, in a way, COVID, because if you'd known that you were going to face the crisis of COVID when you joined HSE, would you have run a mile or?
I don't think you could ever have understood what was sort of coming and like we were in the background supporting from an IT perspective. Like myself and my two kids at home during COVID were just like the clinicians were unreal. And you just, from my own perspective and my team's, it was like, how do we support those incredible people risking their lives every day? What can we do to make it easier for them to do what they're doing? And it was all based around that. And all of my team were the same. And that's when I had actually just taken over as Director of the Health Identity Management Services just at the start of that year. We were looking at building that team together to try and start looking at how we implemented and put the Individual Health Identifier, which is...
The Health Identifier was central to being able to know who somebody was, right, in terms of the vaccine.
Exactly.
I mean, that was such a mad time, really. I mean, did you find overnight that you were part of this whole kind of campaign to make sure that we took care of our population?
So the funny thing is, at the start, there was about 5 of us there at the start that had basically set up our team. There wasn't many of us. And at the start, we actually thought, because the service hadn't began, we thought we would actually just end up pausing it. So my focus at the start was actually, I worked in health business services, the shared services, and my focus was actually getting all of procurement, all of finance, all of HR, all home with their laptops. And these are departments that wouldn't have done remote work. They all were very much desktop driven in their offices and have been for years. So we had to technically...
How many people were you talking about working from home?
Oh my God. I think within that 3-department group, there was about 1,600.
Wow.
And it was getting them all around the country as well. So it was, how do we get them home? And at that stage, God, when you think back on it, there wasn't even enough laptops to give people laptops. So we were actually having to get people to go in and bring their desktops home with them. And then it was trying to work with our IT guys in eHealth. It was like, okay, how do we work together? And I knew a lot of people in there, so it was brilliant. How do we work together to create videos to show Maria where to actually plug bits and pieces in to connect to the internet, to show her how, because a lot of people weren't technical. So they were bringing all this stuff home and there was multiple wires and they were trying to work out how to actually get it live before we were able to give people laptops and get them to connect.
So you're creating basic online learning for them, were you? Little videos and snippets?
We've done videos and snippets. And from that organisational psychology point of view, my team, I was working with an incredible lady, Elaine Lynch, down in Cork, and Elaine's head of comms. And I was like, Elaine, look, we know that people can technically get stuff home. We can technically get them set up. But how are they going to actually manage their teams? What does that look like? It's a complete change of how they live, how they deliver, in a period and a time of extreme uncertainty, and people hadn't been taught those skills to manage remotely or online and engage with their teams. So I went out and spoke to an Irish organisation called Innovate, and an incredible lady, Maeve. I can't remember her second name. Brilliant name. Maeve will come back to me. She is a lecturer in TUD. And I was like, look, we want to try and do something for the Irish community in health to try and actually help them navigate that transition to basically mind their teams online. So how do we make their lives easier and give them the skill sets to be able to do that, to support people, because people are in a really hard place. And we worked with Grow Remote.
I'd say you didn't give her much time, did you? I mean, you were really up against it. So how much time did she have to
we did it in 6 weeks.
6 weeks.
Innovate, the Irish platform, give it to us for free. TUD helped us with the content. We looked at what we needed from a HSE percentage, brought it all together, brought everything together, and then Grow Remote helped us as well, who are an Irish government-backed organisation to support Grow Remote or remote working across Ireland. And the whole thing was created within 6 weeks and went live. And at the time, we were putting it through our comms, national comms, to say, look, this support is here if you want it. And a couple of people were like, people aren't going to need that. And I was going, I'm telling you, I have brought 1,500 people home. They are going to need that support of how do you do things differently. And we had over 1,000 registrations within, I think, 2 days. We had to close it. We ended up bringing it to a certain number and then closed it. And we online graduated 1,000 staff. And then the HSE, Michal Martin, did it for us during COVID. It was all online. And we had everyone from admin the whole way to cardiovascular surgeons who wanted to learn, how do I live and work in this new environment? So that organisational psychology, that support for teams and staff for any transformation is really important. It's really important to have that at the core. What are we going to do to support our people? How do we do that?
I think sometimes people are afraid to ask questions because they think they should know, right?
Yeah.
So if you give them information, they can self-navigate their way through it.
That's it. And it was about creating a community, saying to them, you can all support each other now. So these are all there. So if you have a challenge or you have a question, you don't know how to do something, do that.
So you had some sort of forum, did you, where they could
forum where
answer somebody else's question?
Yeah, they were able to link in with each other.
And what was most important, do you think, of the support you gave them in terms of learnings for them, managing a team?
Well, there was a lot of stuff around managing remotely. What does that look like? And the whole sort of human aspect of going, check in with Maeve, make sure she's okay, have a conversation. This is really hard for everyone. This isn't even just moving to remote work. This is actually moving to remote work when people have serious challenges in their hands. So I'm a single mum. I was looking after my 2 kids. They were incredible. They did no Aberwalia, no homework at all. I spoke to the principal and was like, I can't do this and my job at the moment. And he was like, don't worry. And I was like, but let me tell you, they're out putting out washing. They're helping me cook. They're cleaning.
They're getting their life skills.
Getting their life skills.
This is how you clean a toilet.
Exactly. And there was so many people in my team that had similar challenges with their kids, or they were looking after elderly parents, or people were on their own.
Yeah. And
that's really difficult. So as a manager, you need to sort of have that lens to consider it. And it's not that people don't consider it. Sometimes you just don't think about it. So that checking in with people to manage them in that way and saying, look, Maeve, I know you can't do this work maybe at the moment because you're doing stuff with your kids. And you say, well, can I log on later on and do it? And it's supporting. How do you support and enable people to bring their best selves to work? And that psychology around that, as well as giving people the tools, was what helped them.
And it was very new. I mean, we know that. But there were, I presume there were benchmarks there, because I know eBay for years and years had remote working. So I presume you picked up some of the insights from...
There was huge. And actually the NHS sent me a load of stuff. There was Lady Lauren Bevan sent me a load of stuff. She's brilliant. She's an Irish family, actually. I met her years ago. And she sent me bits and pieces that they had done within the NHS. And we just started trying to share with different people. That course was opened also to the north. We have great relationships from the HSE with the people in the north, and obviously I'm from there. And we opened that whole course up to the people in the north as well, to say, look, anybody in health in the north can do this course as well.
Fantastic. So a real cross-border initiative then.
Absolutely.
Yeah, driven by lots of need, right?
Yeah.
And that kind of talk, okay, the COVID tracker, people, it was in our lives, it was on our phone, it was, everybody was looking at it.
Yes.
And that was your project with your team's project.
The COVID tracker wasn't. That was actually my friend Gar McCreasty. I will introduce you to him. He's incredible.
Oh, very good. I want to talk to him.
Oh, he's brilliant. He's brilliant. So Gar was the one that was driving that COVID tracker. Mine was, we had the Individual Health Identifier. So then we sort of were, what ended up happening was, did all the stuff with HBS and got people live. And then we started talking to the clinicians that were driving the COVID, the CCT system, which was the COVID tracker system for us within the HSE, and also the vaccination system, which was called COVAX, the COVID vaccination system. And we had really good relationships with the clinical people in there, Carrie Ryder, Dr. Lucy Jessup, and we spoke to them about the importance of having a field within this system that we were able to add in identifiers. So an identifier for the individual. So we were able to say, this is Maeve, this is her identifying number, to ensure that we were able to add the PPSN into that data as well, mandatory as well, so that people would be able to give their name.
So if you didn't have the individual identifier, were there risks that you weren't going to be able to match up the right person, with the stage they were at in terms of, you're due in a vaccination, or was it more you've been near somebody who could infect you, or what was the purpose?
Sort of multiple, to be honest. So when we looked at, for example, like the test and trace system, what happened with that was we didn't have the fields in around PPSN, date of birth, and the IHI at the back of that from the beginning. And what that meant was my team then really started to kick up, starting to work, was when we had so many records within the system that by pure chance things just happened. Maeve, you were really upset going in, or you were nervous and you forgot to give your full mobile number. Okay. So a digit was left, or someone taken your details, missed a number. Human error. This happens for data quality reasons all the time. And what happened was multiple records were being left in the system that didn't have the right data points in them, which meant we couldn't text you to say, Maeve, you're actually positive. Or Maeve, you're negative. And we couldn't support from that identity point of view of getting your information to you.
And it was the clinicians who pushed for that, was it?
We went to the clinicians and they pushed to get it into the system to ensure that we were able to actually identify people from their start of their journey within the health service the whole way through to the end of their journey in the vaccination, in the COVID testing. And it was the first time we were able to do it in Ireland. That was our first time of actually being able to identify somebody the whole way through the patient journey. So it was incredible. We also put identifiers in for where there was outbreaks. So we worked with public health as well. And what that meant was, because we had an identifier assigned against, for example, a meat factory, we were able to see, we didn't see it. We enabled the teams. The teams were able to take that data and they were able then to look at it from a public health point of view and actually use the identifier to say there's outbreaks here. There's a need for us to basically have more support from a HSE perspective due to the fact of the outbreaks as well.
You could move quickly and spot the problems.
Yeah.
And I presume other countries may not have necessarily followed the same model. And do you think our model was really importantly different?
Yeah, 100%. And for us as Ireland, it was able to accelerate the Individual Health Identifier as a programme of work. Because when I took it over at that stage, working with my incredible technical colleagues who have been working on it for about 10 years before me, because the legislation came in, the Health Identifiers legislation came in 2014, and then Roisin Doherty runs the technical side of things, and she basically worked tirelessly for years. She is a massive advocate of the Individual Health Identifier and its benefits for patient safety. And they had to build all the technical requirements in order for us to be able to put the IHI and implement it into different systems. So those guys had that all set up. When I came along, we were looking at how we actually adopted and brought that into different systems. And what happened, we thought it would pause in COVID. And then we had amazing clinicians like Kerry and Lucy who said, no, brilliant, we believe in you. We believe this should be here. We know the importance of patient safety for identity management. And they helped us get it into systems that people were building under extreme duress. And they wanted to get the systems up so we could vaccinate. The whole point was get people vaccinated. But they supported us having that field in there. And then the technical implementation from Roisin's team to actually get the identifier in. But what happened then is that my team went from like 3 to 30 very, very quickly because it scaled. We really started to work across multiple parts of the COVID journey to help them with their data quality and making sure that we could...
what parts of the journey would that be?
So, for example, when the nursing homes were, when we were rolling out the vaccination systems to the nursing homes, all the nursing homes had to have identifiers. But at that stage, it was like, where are we going to go to first? So what my team did, it was over Christmas, and I'll never forget, it was literally Christmas Eve, us all having conversations all around that month in December about trying to get identifiers for the nursing homes. But we're waiting for decisions to be made as to which nursing homes that was. So what we started to do within my team is like we're going to do a two-pronged approach here, guys. We're going to take all the list of nursing homes that we've got from the folks in Fairdeal. So we reached out to our colleagues in Fairdeal, got the entire list of nursing homes from them. And what we had was reactive and very strong conversations around, we need these 5 nursing homes now. These are the ones we're going out to tomorrow. We've got the staff laid up ready for them. We're ready to move. But at the same time, I was saying so we had to create identifiers for them. But at the same time, I was running a program with my team saying, create identifiers for everyone. And we'll just keep doing reactively the ones that are needed very, very quickly. But really soon, we'll have the entire list done, and we can give that entire list then through to the technical team, and they can add them in, and they're ready to rock with identifiers for all of the nursing homes.
Okay, so you had individuals within the nursing homes identified.
Exactly.
And so that if there was an outbreak, you could see it as a cluster, I presume?
Exactly.
And then you could move really quickly.
And that the vaccinations could happen. Because if you remember back, the elderly cohort were the ones we were actually wanting to protect as quick because they're the most vulnerable.
Of course.
So those are the ones that were prioritised very quickly to get out. And then we were looking at basically getting the individual health identifier out for staff as well, so that we could actually say, look, these are the staff within the nursing homes that are getting vaccinated in order to protect them and the patients.
So for you, personally, it must have been quite traumatic. I mean, what was the worst part for you, that whole COVID period, that you really felt maybe you would stay in bed, put the duvet over the head?
See, to me, it wouldn't have been work, because the mad thing is work was everyone was so banded together. I had the most incredible team. They were just incredible, and the vision was so clear for everyone as to what we were trying to do. So from an intrinsic motivational point of view, I was very motivated and I had lots of energy for that. I would say it was not being able to see my family, Maeve. It was more that kind of thing of like everyone, just the normal stuff like everyone, of not my family are in Antrim, my sister's in Galway, and it was that not being able to actually see your family was probably the hardest.
Yeah, absolutely.
Like everyone, same thing as everyone. I remember standing outside. My dad has heart troubles, and I remember driving up on Christmas Day, but my sister came up and stayed with me and her husband, and me and the kids. And we drove up to Antrim, but stood outside, like waving in. My dad was watching a Man United match or something, and like waving in. So work was amazing, very busy. My kids were incredible.
Well, that's the understatement of the year. Yeah, very busy. I say you're in a bit of a crisis, actually, but I hear you. But it was the personal side.
It was the personal side. Yeah, the work side. Yeah, I could handle that. It was the personal side for sure.
Yeah, exactly. I mean, we forget, actually. Isn't it funny about COVID? You do forget. I don't know whether the mind is really good and it kind of blanks things out and allows us to forget about them.
Survival, isn't it?
But that wasn't really the end, was it? I mean,
no.
It wasn't really the end either, because you then were part of Ireland's response to the Ukrainian crisis when Putin had invaded Ukraine.
We were.
So what was the gap between those two?
That was 2022. I actually got COVID over Patrick's weekend. Me and my mum both got it, and we think we actually got it in the hairdressers. So we were like, oh man. And I was at home with the kids, and I came back into work after having COVID, and my boss at the time, Joe Ryan, absolute dote, lovely man. He said to me, Maria, I need you to help. There was a huge response to the Ukraine crisis, and one of the streams, Stephanie O'Keefe, who now is the CEO for CUAN, Department of Justice, new organisation that's set up to support domestic violence for LGBTQ. Stephanie, incredible. She was running the entire response for the CEO. And Joe and Stephanie asked if I would take over the data and informatics response, that entire work stream for working with the folks on that.
Well, that's a perfect segue, I think, for us to have a little break. So that's it from this episode of Transform, and thank you to our wonderful guest, Maria McCann, who will be joining us for part 2 on the next episode of Transform. But of course, we mustn't forget to say thank you to our producer, that's Conal O'Moran, and the studio manager, Peter Rice. On sound, we have Alison O'Dwyer and videographer Julia Valkovich. And of course, we're here recording in South Dublin Podcast Studios. Thank you.